I'm, I'm Alice Havard, a researcher at NDOC, and it's my pleasure to be hosting the webinar today. I would like to begin by acknowledging the Bidjigal people as the traditional custodians of the land from which I'm joining this meeting. I'm here on the NSW Randwick campus. I'd also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across this country. We pay our respects to the elders past and present and extend that respect to any First Nations people joining the webinar today. Now, it's my real pleasure to introduce my colleague, Dr. Thomas Santo Jr. as today's speaker. Tom is a postdoctoral research fellow at NDOC, specialising in epidemiology, data linkage and observational research. A key focus of Tom's research has been on the treatment of opioid dependence and comorbid mental disorders, with the view to advancing policies that improve health services for marginalised populations in both prisons and community settings. In today's webinar, Tom will be presenting findings from a study that quantifies the impact of the New South Wales Opioid Agonist treatment program on suicide prevention. As our expert panelist today, we're lucky to have Professor Shane Darke. Shane, who's been with NDOC for over 30 years, will be known to many of you already. He is a world leader in research on morbidity and mortality associated with illicit drug use, and he has specialist expertise relating to overdose and suicide. Tom and Shane will take questions from the audience after the presentation, and you can log your questions for them using the Q&A function. I think that might be it. Tom, it's time to hand over to you.
Thank you, Alice, for the lovely introduction. Thank you all for joining us today as well. Today, we're going to look at the impact of the New South Wales Opioid Dependence Treatment Program to show how providing access to drug dependence services that are evidence-based at a large scale and over a sustained period can not only save lives due to overdose and some of the common causes of death that we are well aware of, but also improves mental and social well-being and ultimately reduce suicide at the community level. I'd also like to begin by acknowledging the Bidjigal people as the traditional owners of the traditional custodians of the land on which most of this work was done, and also pay my respects to elders past and present, and extend that respect to any Aboriginal and Torres Strait Islander people here today. I also want to acknowledge that many of the issues that we discussed today are disproportionately affect First Nations people, and that whatever strategies that we use to try and reduce the disparities among Aboriginal and Torres Strait Islander people must have reducing those disparities at the core of any strategy that we have, national or global, and also focus on reducing these harms across all First Nations people globally, and have those people at the table when we're implementing these interventions and also developing them. Funding and disclosures. So this study was funded by the National Institute of Health and also the National Drug and Alcohol Research Center. Would like to acknowledge those funding bodies, but also note that they played no role in the design of the study, as well as the findings or any portion. I'd also like to acknowledge the opioid agonist treatment and safety study participants for sharing their data, as well as the study team. I'd also like to acknowledge the co-authors. A special shout out to the team at University of California, San Diego, or UCSD. Professor Antoine Chalion is co-first author on this paper, and Natasha Martin, as well as Matthew Hickman, Kriana Barrett, Louisa Degenhart, and the co-senior author, Annie Borges. Without the data modelers, there is no study, so very much appreciate all their hard work in developing the model, the original model that we used to provide data for this study, as well as the current analyses. So before we go into treatment of opioid dependence and how that can reduce suicide, we'll first take a step back and look at suicide as a global public health crisis. So each year, over 700,000 people died due to suicide globally, and young people are particularly affected, with it being the fourth leading cause of death among those who are 15 to 29 years old. Uh, the global actions and global goals for the UN and WHO have set out priorities to reduce suicide by 1/3 by 2030. And there's a number of current prevention strategies that are recommended. Uh, and they're kind of broken into two areas, or two strategy types. So there's individual level strategies, which include reducing suicide at the individual level, or reducing suicidality attempts or completed suicides among those who are at particularly high risk. And that might involve individual level therapies. And then we have population level or population-based approaches, which aim to reduce suicide at the population level. So we'll go more into that in just a moment. So individual level suicide prevention. That may be what you would see when you go to see, say, a psychotherapist for cognitive behavioral therapy, medication management for individuals that are particularly high risk of suicide. And we're aiming to provide support in the immediate time period that someone might be at highest risk, or over time, if they're high risk, if they have high risk characteristics for suicide, as well as treatments for mental disorders that are very closely linked with suicide. And these are typically clinical or therapeutic interventions. However, if we're going to try to reduce suicide by 1/3 by 2030, we also need to use population level suicide prevention approaches. And these are things that you might see like Beyond Blue, or are campaigns for public awareness of suicide, Are You OK Day, also restricting access to means of suicide. So this may be in relation to, in the US in particular, reducing access to firearms is one thing that we've seen has decreased levels of suicide at a population level. Also, pesticides in certain Southeast Asia countries, implementing policies at a national level has been associated with reduced suicide rates for individual populations, or populations across the board. So another strategy that we have that's related to population level approaches is using these type of approaches, which we may aim towards the whole community when we're implementing an approach like means restriction or public awareness campaigns. They may be aimed at reducing suicide rates among everyone, but we also have population level approaches we can use for specific groups that may have higher risk of suicide. And these are approaches like anti-bullying campaigns for students. There's certain senior community centers that have shown evidence in reducing suicide in Norwegian countries, I believe. And this is due to the high rates of suicide among seniors, the particularly high risk for those that are living alone. Providing community centers has been shown to reduce risk among this specific population in certain studies. So these approaches are not necessarily trying to reduce an individual's level of risk at an immediate time period where they're at very high risk of suicide, but they can provide social and mental well-being and support to reduce suicide among high risk, or groups that have higher risk of suicide rates. So one of the subpopulations, and the one we'll be focusing on today, is people with opioid use disorder. So among people with opioid use disorder, we often think of overdose, and that being the highest risk of death among this population. And from Sarah Larned's study in 2019, we saw that that is the highest cause of death among people with opioid use disorder. So that's the 31.5% you see on the left. But suicide is also a major cause of death. So about 8% of all deaths among people with opioid use disorder we found were due to suicide, which is far higher than what we would see for the general population, even when we match individuals by age and sex. So there's an extremely high risk of suicide among people with opioid use disorder, and unfortunately, often due to the conflation between overdose and suicide, which Shane will further elaborate on during the Q&A session. There's a lack of targeted strategies for reducing suicide among people with opioid use disorder. So there's national strategies, like I mentioned before, with population level approaches that may apply to everyone for reducing suicide among people across the general population. But there's no specific strategies that we see on implemented consistently, I guess globally, on a national level or global level that target reducing suicide among people with opioid use disorder. And what we often see sometimes is that the strategies are more geared towards overdose, and because people often think that opioid overdose is a large driver of the suicides that we may see among people with opioid use disorder, we have a lack of approach, and there's a real need there to provide approaches that reduce suicide among people with OUD. So we know from a systematic review that we completed in 2021, as well as recent studies from Priyanka Pranthman in the UK, as well as Samantha College Frisbee in Australia, that being retention in opioid agonist treatment reduces risk of suicide at the individual level. So what we found was about people that are receiving OAT have about half the risk of suicide compared to those who are not. And that's comparing those who are receiving a prescription for methadone or buprenorphine for the treatment of opioid use disorder compared to those who are not receiving that treatment at a specific time. And we found that there's more than half the risk across all time periods, but there's also reduced risk at certain periods. So the first 4 weeks after leaving treatment, there's a particularly high risk of suicide, for example, and self-harm. That's one of the findings from Samantha College Frisbee study that was recently published in Drug and Alcohol Dependence and goes a little bit more in depth to that. But what we can do is provide more support as far as reducing suicide among people with opioid use disorder by more targeted strategies that aim to reduce suicide at specific periods or use specific approaches like combining mental health treatments, etc. The study setting, what we wanted to do was quantify how opioid agonist treatment reduces suicide among people with opioid use disorder, and one of the ideal settings for this is New South Wales, largely due to these robust data linkage systems, which use routinely collected data, such as when people are receiving methadone or buprenorphine for treatment of opioid use disorder, as well as causes of death. There's a large coverage of these routinely collected databases, such as the one that collects the data on when people are receiving and not receiving opioid agonist treatment, if they've ever gotten a prescription, which has been around since 1985 and allowed us to do this study. Another important characteristics of New South Wales is the large coverage, at least relative to the rest of the world, in relation to people receiving opioid agonist treatment if they do have an opioid use disorder. So in some recent studies in the US, we found that people with opioid use disorder, only about 20% in some areas, have ever received OAT, which is the most evidence-based and most effective treatment, not only for suicide, but opioid use disorder treatment as a whole. And that's very concerning. And it's good to see that, at least in New South Wales, we have 89% of people receiving, an estimated 89% of people who have OUD within New South Wales have received methadone or buprenorphine at least once. That doesn't go into retention and things that we'll discuss later, but relative to the rest of the world, that's quite high coverage and allows us to look at whether or not a program over time is reducing suicide at the population level. And there's our star for the higher relative coverage. So the opioid agonist and treatment safety cohort uses this routinely collected data to establish a group of individuals, or to establish a cohort of individuals, that are prescribed either methadone or buprenorphine with or without naloxone for opioid use disorder from 2001 to 2018. And that's what we call spine of the cohort. And the data from this group, which is anonymized and a large group of people, over 45,000, is then linked to a number of different other routinely collected or data linkage databases. So that includes the ones that we collect for causes of death, those that we look at for hospitalizations, those that collect data on things like incarceration or emergency department visits. And what that allowed us to do, or what that allowed the team at University of California, San Diego to do, was develop a dynamic deterministic mathematical model. And this is where I would like to phone a friend if I could. But the UCSD team was able to develop a model that essentially simulates how the OAT program in New South Wales is preventing death due to all causes and overdose over the about 20-year period that we see mentioned in the title there, so 2001 to 2020. They only used data from, or real-world data from 2001 to 2018, but what their model did was account for different periods in and out of treatment. So like I mentioned before, there's a very high risk of mortality when someone leaves treatment, the first 4 weeks afterwards. There's other factors that we know are really strongly related to increased risk of overdose and all-cause mortality, as well as suicide, which include incarceration, the few weeks after someone leaves incarceration, particularly high risk for all of those mortality-related outcomes. And so what this model does is essentially look at how receiving OAT among the whole population reduces all-cause and overdose-related mortality, and that was published in 2021, and essentially simulates individuals going through those different periods. So when they first get on OAT for the first month, or when they first leave, or once they're retained for a long period. So receiving OAT for a long time reduces your risk of multiple causes of mortality. And their model also creates a scenario where, so it simulates what we're seeing happening in the real world. It predicts it into the future. So we only had data from 2001 to 2018, but they predicted 19 to 20 as well. And then it also simulates a scenario where we had no opioid agonist treatment in New South Wales. So it looks at what potential deaths could there have been if we did not provide opioid agonist treatment or access to that treatment for people with opioid use disorder. And so here we'll see a large different number of scenarios and how mortality risk increases or decreases in certain scenarios. But essentially, it looks at different time periods. It follows large population level trends and is able to predict how OAT, or the OAT program, reduces mortality at a population level. Now, for this study, they did not look at suicide specifically. They only looked at overdose and all-cause mortality. And we wanted to see, well, how does that actually affect suicide specifically, using their already developed model, as well as some of the data that we already have access to in New South Wales. So there's multiple reasons for this, as I've mentioned before, but population level impact of a program, we don't have any studies that have looked at how does an opioid agonist treatment program affect suicide or reduce suicide, or if it does, at a population level, even though we know it reduces individual level risk. We have multiple studies that have shown that over time, does this actually have a population level effect? And can we put a number on the number of suicides prevented through an OAT program? there's lack of recent estimates on suicide risk. So Sam College Frisbee study did update some of those estimates as well as what we did in the current study today. And what that allowed us to do was update some of the data that we feed into the dynamic mathematical model that I discussed on the last slide. And finally, again, there's a lack of tailored interventions for people with OUD. So core aim is to estimate the number of suicides prevented by the New South Wales opioid agonist treatment program from 2001 to 2020 among those who have ever received opioid agonist treatment. And given we know that we have relatively high coverage, so that 89% estimated number of people that have received OAT at least once if they have an opioid use disorder, we can estimate that the program is how the program is using or how preventing suicide-related deaths by looking at the opioid agonist treatment and safety study participant data. First step in doing that was recalculating our parameters that we feed into the model, and that involved reanalyzing some of our data from the OATS cohort and calculating what the individual level risk that I discussed previously is about half the risk of suicide for those receiving OAT compared to those who are not, and doing that separately for the community and for prison. As I mentioned before, the original model, which looks at overdose and all-cause mortality, they separated different periods of time as well as being incarcerated as well as the post-release period, etc. So we wanted to incorporate any data that we had in terms of suicide specific deaths and how OAT affects the risk of death across different periods and across different scenarios, and use that data to kind of update and provide a more robust level of data or confidence for the dynamic model. The two scenarios which were created when we developed the original model were a scenario with OAT from 2001 to 2020 in New South Wales, and then comparing that to a scenario without opioid agonist treatment. And we used that to look at the number of lives that were saved due to preventing suicide among people with opioid use disorder in New South Wales. And finally, what we wanted to do was look at whether the model was lining up with the data that we see in the real world. So the 2001 to 2018 data, which is from the cohort, the OATS cohort specifically. So that's what we actually see in the real world, 2001 to 2018. Does that line up with what the model predicts from 2001 to 2020 or 2001 to 2018 within their prediction period? So we'll go more into that in just a moment. But first thing that we did was calculate those parameters that we fed into the model. And unsurprisingly, we found that there was a significantly decreased risk of suicide when people are receiving OAT compared to not receiving OAT from that period during 2001 to 2017, sorry, not 2018, which uses our, again, real world data to feed into our dynamic mathematical model. We saw a small number of deaths for people who were incarcerated receiving OAT, which therefore led us to have what we think this is the reason for the insignificant result there in terms of individual level suicide risk. However, when we look at the larger previous studies that we've had in New South Wales, at least, that have a longer period of time that we look at the data for. So as I mentioned, the opioid agonist treatment database was established in New South Wales in 1985. So when we look at the whole period, there is a significantly reduced risk for suicide while people are incarcerated, as well as once they're released from prison. There's a significantly decreased risk for suicide. However, when we only look at the 2001 to 2017 period, which we needed to do to line up with the model for this study, we did not find significant results there. But we did and we're able to estimate that the New South Wales opioid agonist treatment program from 2001 to 2020, we're now looking at the model data and what it predicted, averted more than 330 suicides in the community, in the overall, and that's 13 in prison and 325 in the community. So what we see in the blue here is our kind of baseline scenario. All of these are model results. So this is what we prevented in terms of suicide, what we estimated. We prevent the estimated number of suicides when the opioid agonist treatment program is in place. So that's our baseline scenario. And we base that off the real world data that we have from 2001 to 2017. And in that scenario, we had around 600, I believe, deaths due to suicide among the cohort. And then in the scenario without OAT, we had just close to 1,000. So in the model predicted scenario where there's no New South Wales opioid agonist treatment program, we had about 338 more deaths from what we estimate in that scenario. So that shows us essentially how many deaths were prevented by having a opioid agonist treatment program that has what we estimate to be around 90% access in New South Wales. And when we then compared how our models predicting the number of suicides for people that are in the community and prison, what our model predicted from 2001 to 2017, it lined up very well with what the real world data showed from 2001 to 2017. So essentially, it means we're pretty confident in our results. Overall, our main findings are that the New South Wales opioid agonist treatment program does have a population level impact on reducing suicide. And this is the first study to show how an OAT program can have that population level impact and quantify it, to put a number to the number of lives saved, as well as the life years saved we see here, and even contribute to how these goals we have developed by the WHO and UN to reduce population level suicide by 1/3 by 2030, how establishing an OAT program can actually contribute to reducing suicide at a population level. Here we just show how in prison and the community, there's about 35% of deaths that were potentially due to suicide. In that no OAT scenario, we prevented about 35% of them, so over 1/3 of the potential deaths among people with OUD were prevented by having a opioid agonist treatment program in New South Wales in place. Potential explanations for why this is. Other studies go into this more at the individual level, but reducing withdrawal symptoms as well as cravings and stabilization of opioid use. So that would be, long-term retention and increased engagement with healthcare services, really key in terms of connecting people that are particularly high risk of suicide with an opioid use disorder to mental health care, as well as other services that may ultimately reduce their risk. There's also improved psychosocial stability that's associated with receiving opioid agonist treatment, and again, potential for co-management with an opioid agonist treatment program provided as widely as it is in New South Wales. One of the main implications of this is that we can reduce health inequalities in terms of the disparities we see for First Nations people that are disproportionately affected by opioid use disorder, as well as suicide, as well as other marginalized communities, to help reduce inequalities, not only in Australia, but globally in terms of First Nations communities or other populations that have an increased risk of harms related to opioid use disorder and particularly suicide. So providing a population level intervention to individuals that are at higher risk or disproportionately affected by opioid use disorder can help reduce those inequities. again, this can be a very effective tool, at least I believe, in expanding global access to opioid agonist treatment. We have the goals that are developed by, again, the WHO and UN. There's many places that don't have a wide access of opioid agonist treatment services or opioid dependence treatment um, available for people with opioid use disorder. As I said, even in the United States, where there's been an opioid overdose crisis for the past however many years, there's only 20% level of people that have an opioid use disorder have ever received opioid agonist treatment. So providing that to also countries that are not high income, using this as a tool to another reason to expand opioid agonist treatment. We know that it works, but we can actually now put a number to the lives saved due to suicide as well as other causes of death. Integrating comprehensive strategies. So that's how do we now combine mental health services as well as integrate them within opioid use disorder treatment, and also use tools like emergency department follow-ups for people that are at higher risk of suicide or that may have had a suicide attempt. How do we have even more targeted strategies by providing services for individuals with opioid use disorder at highest risk? How can we use these findings? Again, expand program accessibility, not only with globally, but within New South Wales. There's a number of studies that show we're not reaching everyone, even within New South Wales, who have different preferences for treatment. For example, there's the hydromorphone trial with Craig Rogers, St. Vincent's, currently going on and showing some promising results that show that in New South Wales, we only have methadone and buprenorphine. There's now the long-acting injectable form, and there are some options, but there's several other countries that have provided other types of medication or even supervised injecting of heroin for treatment of opioid dependence, and how can we increase access further? So that 89% number, again, is only people that have received OAT once in their lifetime. How can we ensure that we're providing services to the community using the opioid agonist treatment program that people want to continue to engage with? Again, providing further training to people who provide OAT or prescribe OAT for how do we assess risk of suicide, how do we reduce that risk, and again, finally, a data-driven advocacy framework. So how do we use these results, maybe not even for OAT, but other types of interventions? Can we produce mathematical models that show they also reduce other causes of death like suicide? And can we use that to advocate for expanding access to drug dependence treatment or even other mental health services, et cetera? All right, some of our limitations, again, only tracking people who've received OAT at least once. So that includes about the 46,000 people and what we estimate to be around that 89% of people with opioid use disorder in New South Wales. So there is some people that may have an opioid use disorder who've never engaged with receiving methadone or buprenorphine for opioid dependence within New South Wales, and so they're not accounted for within our study. So maybe an underestimate actually on the number of lives potentially saved due to the OAT program. Data exclusivity to New South Wales. So obviously this applies to the New South Wales opioid agonist treatment program, which has a higher level of coverage than we may see in other areas, as I've mentioned. So we can't say that implementing a program will save 35% of suicide or prevent 35% of suicides among people with OUD if you implement it in your area. This has to do with a number of levels of characteristics of the program, and it could even be higher if we continue to improve access for people with opioid use disorder to OAT. And finally, the limited incarceration data. There were too few suicides to see a significant effect in terms of receiving OAT during incarceration and reduced risk of suicide. But we know from our review level evidence that receiving OAT in prison reduces risk of suicide. And so further investigation on that, and as well as the post-release period, how does receiving OAT reduce suicide during that period? We know it works and it does reduce suicide, but can we put a population level or quantify that number? Finally, the misclassification limitation. I just wanted to highlight this, and it might transition well into the Q&A and Shane's discussion, given I think the misclassification where people often see that, or often may think that opioids are involved in a majority of suicides among people with opioid use disorder, or those are just being confused as, or suicide-related deaths are maybe being confused as overdose-related deaths. We see only 10% of the total suicides that we have observed from 2001 to 2017 were due to an opioid, or involved in opioid overdose, sorry. So the non-opioid overdose numbers were actually higher for people that died related to suicide. That may be due to misclassification, but essentially we're saying that we're very confident that this isn't an issue with a coroner mixing up an overdose and suicide. This is a true completed attempt. And thank you all for attending and watching the webinar. Again, those are the final results, and feel free to contact me with any questions or comments. Thank you.
Thank you, Tom. That was such an excellent presentation. Some really impressive analyses there, and really heartening that you've been able to provide this evidence about current service provision having such a positive impact on saving lives. Shane, I was going to welcome you and ask if you might like to reflect on the work that Tom's just presented.
Thanks, Alison. Thanks, Tom, for that, I think, incredibly important study for a number of reasons, but the two emphasising is addressing an issue which is a major clinical issue, suicide generally, but amongst people treating people with opioid dependence, this is a major clinical issue. And I suppose the other thing I'd just like to say is, for the people in treatment out there, you can make a difference. It's easy to not see it during our daily battles, but treatment can make a difference across a whole range. And in this case, what price do you put on a life? 330 plus lives saved, possibly conservative measures. So I suppose just by way of giving a little bit, that was all focused on death. But I think with people with treatment, when someone's walking through your door as a treatment agency, something like half of the women and a third of the men will have a history of a suicide attempt. Why does that matter? It matters because obviously it's reflecting distress and despair, but it also matters because one of the strongest predictors of a fatality is a previous attempt. And so what you're having is people walking through your door who have opioid dependence, but they're complex cases. They've got 20% will have a major depressive diagnosis current, which is a risk factor. What we see, a quarter will have had other forms of self-harm. What you have are all the risk factors we know for suicide, but at far higher levels. Child abuse, half the men, 3/4 of the women. These are all massively important, and the history in and of itself is massively important. So the thing is, people in agencies, and I would say not only opioid, I know this was on opioid substitution, but residential agencies are dealing with complex issues. It's not just dependence. And it's important for, I think, for funders to realise it and for clinicians to realise that. So I think, as Tom was saying, overdose and suicide are two separate issues and require separate interventions. They're not unrelated, but most overdoses are accidents. And as Tom said, with the work we've done over the years, so interestingly, most opioid suicides occur by means other than opioids. Now, increasing general, reducing substance use and chaos reduces overall risk, and that's true. But we worked some years ago now with the network of alcohol and other drug agencies to produce the suicide assessment kit, which lives on the NDAR website. why is that? And what we're trying to do, what the agencies were interested in saying is, this is an issue for us, but the information's never holistically put in the one place. I'm not going to use the word silos because I've been hearing about silos since the 1980s. I will not use it again. But looking at things like screening for suicide, I think there's always some people have a reticence. It could increase risk. There's no evidence for that, and problems not talked about don't go away. And that may need to be screened on a, risk goes up and down. Putting all the risk factors from a history when someone comes into the treatment into the one document, into one place, so that all the different clinicians dealing or have access to this, what's happening here. Looking at your policies, it should, and procedures. I think basically the take-home message is this is an important issue that's going to affect all agencies. You can make a difference, and we can always do better. I congratulate the authors on it's a great piece of work, and I think incredibly important.
Thanks, Shane. I think those are really important points about some practical things of how to deal with the risk that is present in this population, and it seems to be having an impact.
And just to add, the connection with other comorbidities, as well as what you mentioned, Shane, with trauma, we know that there's a long-term impact of things like trauma, and addressing those things that are also separately linked with suicide. Or people that say don't have an opioid use disorder, we know that childhood trauma is associated with an increased risk of suicide on its own. So how do we add to what we have already in an OAT program to continue to, what you said with break down silos, but integrate care in whatever way we can, provide trauma-informed care, and continue to increase the effectiveness and retention of people with opioid use disorder.
I mean, chronic pain's also an issue, Tom.
Yeah.
People who are being given opioids for chronic pain, independent of depression, is a risk factor for suicide.
I do have a few questions of my own, but I do want to just remind the audience to post your questions in the Q&A. We've got some time to put those to both Shane and Tom, so feel free to pop those in. In the meantime, I wanted to ask, you mentioned, Tom, that one of the potential contributors is around treatment of co-occurring mental health disorders. I'm just wondering to what extent that is accessible to people on ODOR with OUD currently in New South Wales.
So I don't know if we can, or if I have a number for that specifically with people with opioid use disorder, but I will say that it is difficult. We know that there's large gaps often for seeing a mental health provider, that people that are experiencing social disadvantage, it's really hard to access mental health treatment often times. And so we did a review with each specific mental disorder, and the depression, we saw that major depression, for example, current as high as 33%, anxiety disorders over a third as well. How important it is to make sure that treatment's not only accessible, but integrated if we can. But it's about, I think, funding, and how maybe we could even use modeling to show that if we expanded these services further, and it made them more accessible to the whole population, or people with opioid use disorder specifically, how many more suicides could be prevented, or even more. We know mental disorders are linked with increased risk of overdose as well. How many more overdoses could be prevented? So, I think that in Australia, at least, we know that there's certainly some problems with access for mental health treatment, and in the United States as well. I know there's been some studies on population level, even about a quarter of people that have a co-occurring mental disorder and opioid use disorder have been able to see a psychologist or psychiatrist in their, I think, lifetime. So yeah, definitely a large room for improvement there.
I was thinking about the point that you made around how generalizable these results might be to other settings, given that there are, well, obviously coverage of OAT is one big difference between New South Wales and potentially other settings, but also I suppose that, that access to other services would be another reason or a consideration, I suppose. So I don't know if you can say any more really about how these results might apply anywhere else. Can we, do we think they're completely not indicative, or are they I guess I'm wondering how sensitive the model is to those different estimates, different inputs.
Yeah, so looking at it's using data from such, I guess, a large cohort as well as a large period of time that looks at, population level trends. It doesn't just because we only looked at, certain time periods on and off treatment and in and out of incarceration, it does account for, whether mental health services were expanded during a certain year or something like that.
Yeah.
And so 2000 to 2017, I'm going to guess that things were changed in Australia, for example, in some ways. And so there probably is a mix of how accessible mental health services were over that period. But again, this is what we can attribute at least to the OAT program. And we're quite confident that at least given how many places have such low coverage, establishing that would certainly prevent a number of suicides. Even I think, ideally we want to also provide mental health services as well. Cost is a major problem with that, especially on the for the individual level of prevention. We know that OAT is cost effective. It's actually relatively cheap for methadone. And if you don't have that as an established program, obviously we want to go for the ideal scenario for providing, one-on-one psychiatric care. But can we prevent suicides by just implementing a population level approach that may be more cost effective or realistic for non-high income countries, especially?
Alice, I think the findings would be reasonably robust. I mean, not going to comment on the sensitivity analysis because I wouldn't have a clue what it meant.
Sure, Shane.
But I'm going to comment on everything else. Yeah. Look, what we do know, it's not going to stop me. What we do know about long-term stable treatment, and Alice, you remember when we were doing the Australian Treatment Outcomes Study, longitudinal study, drug use goes down, mental health improves, there's more stability, there's, as Tom's alluded to, pulling people into a system where they're getting referred and seen by various professionals. So I think it fits with the general picture that long-term stable treatment saves lives. And one of the ways it saves it is through suicide. I should mention the relation we talked about comorbidity, but we haven't, but physical health improves too. And of course, very poor physical health is, if you're feeling terrible all the time and dysthymic, it can be a driver for suicide, or for at least for suicidality, for suicidal thoughts. So, I mean, there's the comorbidity. I think a lot of times we think of comorbidity as psychiatric comorbidity, but we should also consider physical comorbidity, particularly amongst older people. And one of the other things about drawing, you've mentioned older people, which as I've gotten older, I've become more and more interested in. There's a lot of older opioid users are quite isolated. A lot of their friends have died. And sometimes having someone being engaged in treatment, it gives that out of the house some sort of social interaction with people who may actually listen to you. I think that's important. I think it's really important. That's very nebulous, but I think actually being able to go and talk to clinicians and them listening to you is important.
That's a good point.
And just to answer your question briefly, Alice, the model would be more sensitive to those factors like that are related to the opioid agonist treatment program that Shane's mentioning, like, do you have to for example, come in to receive your dose. We know for some people that's a barrier. For some
Yeah.
people, that's actually something that they want to interact. Maybe not have to go in, but are they able to connect with people or other services at places like KRC, or that, you know, interact with, like, what are your characteristics of your program? Do you charge people a certain amount? Is that a barrier? So those factors would be what are really affecting whether or not these results are applicable to somewhere else. But also, you know, can we even prevent more deaths due to suicide or other causes?
Yeah. We actually have a related question from Jennifer Holmes here about, you know, we're talking about the treatment program itself, engagement with the program potentially being the thing that makes a difference. And Jennifer's asking whether there's potentially a difference between methadone or buprenorphine and the characteristics, I suppose, of that treatment. But I suppose you can't.
Someone with the last name Santo Jr. did do a review where we looked at the medication separately, but I do not remember. I don't think that there was a difference at the review level, at least for impact on suicide. I can definitely double check that though, but I believe that they were saying, if anything, I think methadone was decreased risk, but I should check that before I speak.
Jennifer has, of course, been at the front line in clinical work for all the time that I've been in this field, which we won't embarrass anybody by saying how long that is. But I mean, in terms of, I suppose what the question here is, methadone and buprenorphine seem to be, in terms of general treatment outcomes, look pretty similar. There are reasons you'd use buprenorphine. One, because if someone's got respiratory disease, it's less respiratory depression. But the issue here is, would it, you know, there are people as who would want to come in, or people who are at higher risk. Depot buprenorphine, I think, is a game changer, but there'll be people that that need not to just come in once a month or once or 2 months. That it might, you know, I think in terms of these medication schedules, you can't just introduce it. There'll be people at different risks with different needs. And so some people may, you know, you might be liberating for some people to have depot bute, but it may actually not be good for someone who's in acute crisis.
Yeah, and it's about having, you know, access and options, right? Like if,
access,
you know, in the US, for example, there's a lot of places that have, you know, they'll prescribe buprenorphine, but there's no access to methadone. And Alice, you were asking about applicability of results. The results aren't going to be applicable if you don't have access to methadone, for example. So that's going to be the major factors there. But I mean, there's a major barriers for, you know, some places it's actually more available because of cost, but yeah, access and options are critical and will help, you know, engage more people in treatment, which is not too surprising, but yeah.
And there's a question here from Patrick Birtles around whether you saw any improvement related to the availability of naloxone. But I'm thinking that I mean, that's kind of going back to the issue around conflation of overdose and suicide, and you know that potentially that wouldn't have a major influence, given that many of these suicides aren't opioid overdoses.
Yep, just about 10% so involved in opioid overdose. So, you know, obviously we want to expand naloxone availability, but and certainly for the overall model, which the one published in 2021, overdose-related mortality, I'm sure that having an expanded naloxone access program would certainly be a part of how effective OAT program would look in that model.
I mean, basically anyone using opioids or being prescribed opioids indeed should have naloxone valve. And now you've got the nasal formulations. Some people, if they're not got a history with injecting, they're not necessarily comfortable to give even an intramuscular injection, but everyone can put a spray up a nose, and it's so yeah, it's basic public health. It's good public health.
Thanks. I'm going to sneak in one last question of my own before we finish up. And that's just around the number of lives saved over this approximately 20-year period. Do you have a sense, Tom, how that compares to other population level strategies or interventions that have been implemented for suicide prevention?
Yeah, there's not too much that I was able to find that can actually put a number to it. So that's the other, I guess, thing about using this type of approach is how can it be used to look at population level interventions and how can we quantify it. The other stuff that's out there looking at means restriction is typically like, if we put this policy in place, what are the trends over time? And it's pretty much, it's what we can work with, but there's few that have been able to quantify the number of suicides for any type of interventions. I believe there was actually one that I found for mental health related stuff in Australia, but other than that, it's one of few. And can we use this approach for other interventions? I think so.
Yeah, so you're leading the way. Nice.
Well,
how much
the UCSD and our mathematical modeling friends, but always happy to help and interpret.
I mean, how much do you value a life? I mean,
Exactly.
it's moneyless. I mean, each of these suicides deaths is a tragedy, and it's a tragedy for not just the person but those around them.
Yeah.
To me, putting money into something that reduces suicide is money well spent.
Absolutely.
Yeah, thanks both. I completely agree, and I think this is obviously really important work and really critical information for service providers, health system planners to be aware of. And I want to thank you both for sharing this information with our audience today.
Pleasure.
Thank you. Thank you, Alice.
Okay, so just before we wrap up, I'm going to just let you know about our webinar next week, which happens to be the last one of the year. So on November 21st, we'll be hearing from NDARC's most recent PhD graduate, Dr. Crystal McDonald, who'll be presenting her research on factors that influence court diversion outcomes in the New South Wales local court, including defendant and offence characteristics. Then during the webinar end of year break, we're going to, NDOC's taking the opportunity to run an information session for anyone who's interested in finding out more about doing a postgraduate research degree at NDOC. So if this is of interest, we'd love to see you in a Zoom meeting on the 5th of December. Please feel free to welcome those details onto anybody else that you may know that is interested in exploring research degrees. I think that might be all we have time for today. I hope you all enjoyed the session. We look forward to having you join us next week for the last one of the year, and I wish you all a good afternoon.